Good afternoon, everybody. Lena had asked me to make some comments about issues that might bear on the design of studies that involve human outcomes. And so in the spirit, as Andreas was talking about aspects of exposure, that details about exposure that we need to take into consideration in trying to make sense of the confusing epidemiologic literature, I'm going to be talking about aspects of outcome measures that we also need to take into account that may bring some clarity. No disclosures. And there are a wide range of issues that are relevant, but I selected three to focus my comments around. First, at what age should we assess children, and what outcomes should we measure at these ages? And then a broader question is, how do we think about the practical importance of treatment group differences that we might see in relation to anesthetic exposure in children? How large does an effect size have to be before it can be considered to be important for a patient and for a population? So let me address the first question, when to assess neurobehavioral outcomes. Now, there's no single good answer to this question. It really depends upon a lot of factors. If your goal is to conduct a randomized trial comparing, say, regional awake to general anesthesia in infant surgery, then it's most feasible to conduct follow-up assessments of those children relatively soon. Both logistically and financially, it's a lot easier to follow up within the first few years of life, such as the gas trial that's been mentioned. It's very hard and it's very expensive to keep cohorts together over many years. We're trying to assess children at age 5 in gas, and it's quite challenging. Now, if the goal is to assess outcomes with what most people consider to be clear public health import, and maybe provide a sufficient basis for changing clinical practice, this might suggest you look at outcomes such as intelligence, IQ, learning disability, attention deficit hyperactivity disorder. Everybody agrees these are bad things for kids, and we want to prevent them. So if those are the outcomes of interest, it's hard to do that in the context of a prospective randomized trial because you've got to follow the children for maybe as long as 10 years. So most of the studies, as mentioned, where these outcomes have been the focus have been retrospective. They've involved getting outcome data on children at older ages, at school age, and then looking back to see whether or not the risk is related to the children's anesthesia exposure. So the PANDA study, the RAIN study, the Mayo studies are all examples that have employed this kind of design. This might also require relying on data that were already collected for not for research purposes, but for more administrative purposes that are completely unrelated to anesthesia. So Lena and her colleagues used the New York State Medicaid database to see which children had ICD-9 procedure and outcome codes that suggested they received anesthesia, and were able to look to see the relationship between the exposure and the outcome using those data. But there are pluses and minuses to all strategies, and when you use data that were collected not by you, but by some other people for non-research purposes, there are always issues about data quality, consistency in application of criteria, and so on. Now, there are some advantages of assessing children during infancy. It's possible that you face less residual confounding. Scores on neuropsychological tests, especially at older ages, are sensitive to so many other factors, biological and social environmental factors, that it can be very hard to measure all of these factors well and to adjust for them in the statistical analyses. And this is less of a problem if we're talking about infancy. For instance, socioeconomic status doesn't become a predictor of children's performance on these neurodevelopmental tests until the second year of life, about 18 months of age. After that, it becomes the most important predictor. But before 18 months of age, we don't have to worry so much about confounding by SES. And in principle, and all other things being equal, which of course they never are, the less time between the exposure of interest and outcome measurements results in greater sensitivity and validity of the assessments of treatment effect. So that's the advantage of infant assessments. There are a lot of disadvantages. The scores have very good what's called concurrent validity. They tell you how that child is doing meeting the age-appropriate milestones at the time of assessment. What they don't do very well is to predict what the child will be doing at age 7 or 10. There's a very poor correlation, poor predictive validity of these scores at 1 and 2 years of age. And there are additional challenges in interpreting the results of infant assessments. First, we don't have a baseline of pre-anesthesia assessment of children's neurodevelopment, typically. It would be extraordinary circumstances if we did. So we're trying to interpret a possible effect of anesthesia without having a baseline assessment to compare the children's performance to. Also, children are changing very fast in development, and so what we're trying to do in identifying an anesthesia effect is to distinguish change that is occurring anyway as a result of normal development from change that can be attributed to something like anesthesia exposure, and that can be very, very difficult. Now, why are infant tests so poor in terms of their prediction? It's not because the tests are not good. As I said, they have good concurrent validity, but early development is highly dynamic. We're trying to capture a moving target. There's also a limited range of things you can ask a child to do. We have to infer what they know by changes in their behavior. So a change in sucking or activity in response to stimuli tells us that the child noticed something novel. Or a change in looking preference after you expose the child to something continuously until they lose interest, and then you slightly change the stimulus and suddenly the child locks in their attention again. That tells you that they notice the change. But we can't just simply ask the child, what do you know about? We have to infer it from changes in behavior. There's also a lack of continuity between the different response modalities that are available early on and those that can be used later, and with language being the most obvious difference in terms of the modality we can rely upon to have the child tell us what he or she knows. And then there's the issue that there are certain late maturing higher order skills, such as those Andreas talked about, that really can't be assessed in infants or even in animals very well. And that would include things like executive functions, which is the ability to delay gratification, to plan, to modify strategies, to formulate and test hypotheses, and so on. So it involves a lot of abstract reasoning. You just can't test those in young kids, and yet they might be very sensitive to anesthesia exposure. We just don't know. So what outcomes to assess? And here I'm speaking in the context of an individually administered battery. A child comes in to a clinic and we put them through some neurobehavioral assessment. Usually when people have applied factor analyses to very large batteries of neurobehavioral tests, they identify several broad classes of abilities like language and communication, attention, concentration, memory, problem solving, and so on. Now there's the number of neuropsychological tests available is very large, and so of necessity whoever does the assessments is going to have favorites and they're going to make choices. It would help a lot in making those choices if we had a very deep biological understanding of the likely mechanism or mechanisms of anesthesia neurotoxicity. In the absence of that, typically studies just administer a broad range of tests that sample all of these different areas, thinking that maybe anesthesia isn't related to all of them, but by including them, we won't miss something very important. Now, the problem is that each of these domains can be decomposed into subdomains. So just for instance, the language and communication domain includes both receptive and expressive communication. And we can break both of those down further. So I've broken down expressive communication into speech production, that's simply oral-motor coordination, phonemic and syntactic skills, confrontational naming, retrieving names of things, fluency, ability to construct sentences, the ability to tell stories, to talk at a paragraph level, and the ability to write. So when we say this study didn't find a difference in language skills as a result of anesthesia exposure, whereas this study did, the devil really is in the details. We have to make sure that those two studies were measuring the same kind of language. It's probably the case that the subdomains are not equally sensitive to anesthesia. And so studies that measure different aspects may get different answers, not because one of the studies is wrong, they could both be right, but they're just measuring different things. And the same thing is true for attention, where we can parse this domain into several different important differentiable subskills. So this is basically what I've said. Not all tests labeled with the same name assess the same subdomain. So we have to be careful. This might be one of the reasons why there's inconsistency across studies, is we're comparing apples and oranges rather than apples and apples. So the implication of there being no logical terminus of this hierarchical branching structure within each domain is that the investigator has to decide where in this branching structure to enter in order to construct an assessment battery. And this, where the right place is, it's going to depend upon the research question. So if the interest is in estimating the societal costs of an exposure, then you want to take tests near the top of the branching structure. These are called apical tests. These are things like IQ that everybody understands, at least they think they know what it is, and it's something that we want to protect in children. But if we want to take a more analytical approach and understand the neurodevelopmental bases for an exposure-related performance deficit, then we might want to focus farther down the tree structure on the building block functions and to get a more detailed understanding of this of a difference at the apical level. But the farther down you go in the tree, the less certain is the functional importance or significance of deficits. And generally also, we're getting into the realm of more experimental rather than well-standardized tests. So the psychometric properties of the tests are not as well understood. And so people would be less likely, I think, in response to change clinical practice based on differences found way down at the bottom of that hierarchical structure. This is actually the same data that Lena mentioned in the introduction, that it's likely that different types of outcomes are differentially sensitive to anesthesia exposure. And in the RAIN study cohort, they found that individually administered neuropsychological assessments at age 10 years, particularly language, were associated with anesthesia, as were ICD-9 clinical diagnoses for different types of disorders, but school-based standardized tests were not. Although even here, as she mentioned, some studies do provide some evidence that standardized achievement tests are sensitive to anesthesia exposure. So it may depend upon whether those tests are given individually or in a group setting, whether they last all day or just an hour. There's all kinds of factors that could explain why one study would find a result that another study wouldn't. It's also important to note that no test assesses a single functional domain. To do well on any particular test, a child has to do a number of things well. Conventionally, tests are described as language tests or attention tests. This one is called the Ray-Osterreich complex figure, and it's usually called a visual motor integration test. This is presented to the child on a card. The child is given a blank piece of paper and some markers and asked to copy this figure. The figure remains in front of the child while they do it. Now, why might a child not do very well on this? It could be that their visual spatial analysis, their ability to see details, how details fit together in the broader context of this figure is impaired in somehow, and so leads them not to copy it very well. Or it could be they have some fine motor problems. They can't hold their marker very carefully, very well, and so their figure is not very good for that reason. Or it could be they perceive the details and the organization of the figure, but they have a hard time with this cross-modal transfer to the motor system and outputting it. Or it could be they have executive function problems where they have difficulty with planning and sequencing. They start in a funny place and they try to put the figure together from details, but they can't see the forest for the trees, basically. Or it could be that it's a behavioral regulatory issue. They're impulsive and they just jump right in and then discover that they've gone awry and they can't recover. It could be they don't care. They can't figure out why you want them to do this, and so they aren't motivated, so they do something very slapdash. Or it could be they're very tired and they've been through a lot of testing. So by itself, you don't know why a child has done poorly on this figure. And it's only in the context of a more comprehensive evaluation that you can start to identify, formulate hypotheses about what this child's difficulties are. So in choosing tests to include in a battery, as I've mentioned, there are lots of considerations. First, the goal of the assessment, whether it's to guide public policy or clinical practice or to clarify basic neuropsychological mechanisms of effect. Children's ages is a very important criterion. In a 2-year-old, about all you can do is 45 minutes and do the Bailey scales of infant development. If you have an 8-year-old, you can do a 6-hour battery of tests. And if you're studying children that span age 3 to 15, that further limits the number of choices of your outcome assessments that you can use. The characteristics of the study population, that is what their primary language is, whether it's a multi-site trial that involves international samples, that might limit the number of outcome instruments that you can use. The length of the time available, if you have 1 hour versus 6 hours, whether the assessment is being done in the field or in a clinic where there's reliable electricity and computers and so on, and the level of training of the assessors. Some neuropsychological tests require quite a bit of clinical skill to bring the child along, and if you just have psychometricians who are less experienced, that could limit the kind of instruments that you use. Now, I want to move on to the third question, the interpretation of neuropsychological test scores. The test performance is a little bit different than some indicators. For instance, in a tumor, you've got abnormal cell morphology. Changes in neurobehavioral test performance represent just quantitative rather than qualitative deviations from normal expected behavior. You see more or less of behaviors that are normally present in a child. And these tests, I do them all the time, but I admit they're very blunt and noisy as probes of the central nervous system. But how you think about that is not so clear. It could be that any deficit in performance is worrisome. It means there's something going wrong in the brain. And maybe this is just the tip of the iceberg. The alternative perspective, which is frequent, is that people say a deficit, unless a deficit is so severe that a child meets diagnostic criteria, it's not really very important for that child's well-being. Now, I think that's the wrong perspective to take, but it's one that many people have. Let me take as an example this Ray-Osterreich complex figure. You might say, who cares if a child can copy this figure? Children aren't, this isn't a real-life skill. But whatever this test is assessing, it's a pretty good proxy for a clinically significant impairment. I did a study of 8-year-old children with a congenital heart lesion, TGA, that had been repaired. And at 8 years of age, I had them copy this figure. And I did what I called a clinical sort. I sorted the child's copy of this figure into one of 5 categories in terms of the degree to which the child preserved the overall organization of the figure. So category 5 was the best, and category 1 was the worst. And I provide 2 examples of each category here. And then I looked to see whether or not the child had to leave their school classroom every week to get special education in some academic subject. And what I found was a dose-response relationship. The children who had the worst copy, the category 1, about half of those children were identified as not making adequate progress in school and needing to leave to get special help. And down to the best copy, category 5, fewer than 10% of the children had been identified to receive special remedial services. So this figure, whatever it's assessing, is sensitive to something very important about the child's success in this critical setting. Now, how large does a difference in score on a continuously distributed test have to be in order to be important from a public health standpoint? Now, it turns out that, well, the top distribution is just the normal bell curve for IQ in a population of 100 million. The average should be 100, and you can see over on the left-hand side at 70, about 6 million of this 100 million population will have an IQ below 70, which is the criterion for, these days, intellectual disability. And about 6 million are in the gifted range, above 130. Now, if we shift the mean IQ in this population by 5 points so that it's now 95 instead of 100, and all other characteristics of the distribution remain exactly the same, what we see is instead of 6 million intellectually disabled children, now there's 9.4 million. So we've increased by between 50 and 60% the number of individuals in that range. And similarly, we've reduced by half the number who are intellectually gifted. Now, I would say that on a population basis, this is not trivial. Even though an IQ shift of 5 points, many people would say, well, that has no clinical import for that individual child. For the population, I think this has big implications for in terms of the intellectual resources available to the population. And this is not just a statistical abstraction. These are real data that we published more than 30 years ago in a study of children's lead exposure. And what we see are cumulative frequency distributions of children's verbal IQ scores stratified by the amount of lead in their teeth, which is a good cumulative marker. The left-hand distribution is the children who had high lead, and the right-hand distribution is the children with low lead. And what we saw was that there was a difference in the medians of about 5 or 6 IQ points. So, like the previous example, but about 3 times more children in the high lead group had an IQ, a verbal IQ below 80, and at the top end of the distribution, the high lead distribution topped out at 100% well before the distribution for the low-lead children. And it wasn't just in the tails that these two distributions differed. They never crossed, meaning that children in the middle of the distribution were also being affected a little bit. So what's the implication of this? A lot of times when the public health importance of a risk factor is talked about, people only talk about the effect size, an IQ difference of 1 or 2 or 3 points. But the population significance is really a function of effect size and the prevalence. So for anesthesia, if we assume the figure you always see is about 1 million children per year in the U.S. undergo general anesthesia. So in a cohort of 0 to 5-year-olds, that would mean 5 million children out of the 25.5 million 0 to 5-year-olds in the U.S. If anesthesia reduces a child's IQ by 1 point, the total IQ loss in this 0 to 5-year-old cohort would be 5 million points. A reduction of 2 points would be 10 million. And if it were as big as 4 points, it would be 20 million. Now, I do a lot of work in environmental health, and I get this kind of question a lot. And so I did an analysis a couple of years ago, and it was published in Environmental Health Perspectives, where I combined the effect size and the prevalence or the distribution of a lot of different risk factors for children's IQ and calculated the total number of IQ points lost in this 0 to 5-year-old cohort. So for brain tumors, for any individual child, it's about a 1 standard deviation impact on IQ, but fortunately brain tumors are not very prevalent. And so the total number of IQ points lost was 37,000. But we went up iron deficiency 9 million, ADHD 16 million, preterm birth 34 million. And I've put these arrows in if anesthesia has a 1-point impact on children's IQ, it makes it about equivalent to the burden associated with traumatic brain injury in U.S. children. If it's a 2-point loss, it's between iron deficiency and ADHD. And if it's 4 points, it's the most significant risk factor in my analysis other than preterm birth. So I think this is a big deal, and this is why there's such urgency in my view that we need to get a good answer to this question. Thank you very much.